All right, let's get right into it. Something really fundamental is changing in American healthcare, and it affects, well, pretty much everyone. It all boils down to one simple but huge question. How do we pay our doctors? We're finally moving away from a system that's been around for decades, and it's a massive shift.
And that really brings us to the core question of this whole thing. For the longest time, our healthcare system was built to answer this in a very particular way. But that answer is changing, and you really need to understand why.
So, to get a handle on where we're headed, we gotta look back at where we've been. For years and years, the system was built on a simple idea, but boy, was it a flawed one. It was all about quantity over quality. Now, the old model was called fee-for-service. Think about it like this. Imagine you pay a mechanic for every single screw they turn and every bolt they tighten, whether or not your car actually runs when you drive it off the lot. That's pretty much how we pay doctors, for every single test, every procedure, every visit. The more stuff they did, the more they got paid. The new goal? It completely flips that on its head. Now, we want to pay for the car that runs well, not for the number of screws turned. And the engine driving this old, broken system? It was this thing called the Sustainable Growth Rate, or SGR for short. It was supposed to control Medicare costs, but honestly, it was more like a ticking time bomb. I mean, picture this. Every single year, this formula would call for a massive double-digit pay cut for doctors. And every year, Congress had to scramble at the last second to pass a fix just to stop the whole system from driving off a cliff. It was this crazy, predictable crisis, and everyone agreed this can't go on. So, back in 2015, something pretty amazing happened. Lawmakers actually came together to finally rip up the old rulebook and write a new one. And let me be clear, this wasn't just some small tweak. We're talking a total rewrite of the entire philosophy of paying for healthcare. And that new rulebook, it has a name. It's called MACRA. Yeah, I know, the full name, the Medicare Access and Chip Reauthorization Act, is a mouthful. But all you really need to know is that this one law got rid of that broken SGR system for good and set the stage for everything that came next. This was the moment we officially started paying for value, not volume. And just look at these numbers. Seriously, they speak for themselves. In a political world this divided, getting that kind of agreement is almost unheard of. But that's how you know this wasn't some partisan squabble. There was this huge, overwhelming consensus that the old system was just plain broken, and a new direction was desperately needed. Okay, so MACRA is the law, but what did it actually create? Well, it built this whole new framework called the Quality Payment Program, or QPP. This is where the rubber meets the road. It's all about rewarding doctors for giving high-quality, efficient care, and this is a big deal, for the first time, actually penalizing them for poor performance. All right, so if you're a doctor, what does this actually mean for you day to day? Well, under the QPP, you basically have two main paths to choose from. Path number one is called MIPS. Think of it as the default setting that most people are on. Path number two is a bit more advanced. It's about joining something called an Advanced Alternative Payment Model, or an APM. So let's start with MIPS, because honestly, when this all started, this was the path for almost everybody, including most specialists, like vascular surgeons. So MIPS, it stands for the Merit-Based Incentive Payment System. The whole idea was to take a bunch of clunky old reporting programs and just mash them all into one. At the end of the day, a doctor gets a final score based on how they did, and that score decides if they get a bonus, get dinged with a penalty, or just break even. In its very first year, here's what that score looked like. As you can see, the biggest chunk, 60%, was all about quality. 25% was for promoting interoperability, which is just a fancy way of saying, are you using electronic health records the right way? And then a smaller piece for improvement activities. And what's really interesting is that cost was set to zero at first, kind of giving doctors a chance to get used to the new system. But, and this is a big but, here's where we hit a snag. MIPS is kind of a one-size-fits-all system, and this quote just nails the problem for specialists. Imagine you're a top vascular surgeon, right? And you're being graded on how well the hospital does on knee replacements or depression screenings. It makes no sense. It has literally nothing to do with what you do every day. And that exact problem, that mismatch, is precisely why that second path is so important. It represents the future. It's all about designing custom payment models that actually fit the care being given. Which brings us to these alternative payment models, or APMs. If MIPS is the generic, off-the-rack suit, APMs are the custom-tailored version. Instead of that generic scorecard, an APM is built for one specific thing. Maybe it's for managing a chronic condition like diabetes, or for a single big procedure like a heart bypass. The whole point is to finally line up the money with what actually works for patients in that specific situation. So what does one of these look like in the real world? Well, a great example is an ACO, or an accountable care organization. This is where a bunch of doctors and hospitals all agree to work together as a team to take care of their Medicare patients. And the deal is simple. If the team provides great care and saves money for Medicare, they all get to share in those savings. It's brilliant, right? It actually rewards teamwork. Okay, this can still feel a little abstract, I know. So let's make it super concrete. Let's look at a case study of how one specialty, vascular surgery, has been busting their tails to build their very own APM from the ground up.
They decided to focus on a condition called peripheral artery disease, or PAD. And the reason why is because the scale of this problem is just staggering. 20 million people in the US have it. I mean, to put that in perspective, that's more than the entire population of Florida. And the cost to treat it is through the roof, which makes it the perfect target for a much smarter way to pay for care.
And this is exactly why a custom model is so desperately needed here. You see, treating PAD isn't a one-person job. It's a team sport, a really, really complex one. You've got podiatrists, cardiologists, primary care docs, wound centers, the list just goes on and on. Trying to coordinate all of those people is a huge headache. And that old fee-for-service system, it gave them zero reason, absolutely none, to work together. So the Society for Vascular Surgery, the SBS, they saw this problem right away. Look at this timeline. The same year MACRA became law. Boom! They put together a task force. And they've been grinding it out with Medicare ever since, trying to figure out what good quality and good value even look like for their patients. Let me tell you, this is not easy work. It's long, it's hard, it's expensive, but it just goes to show you what it takes to build something that actually works. So after all that, where does this leave us? What's the bottom line here? What's the big takeaway from this massive, ongoing shift in healthcare? Well, the most important thing to remember is this. The move from paying for more care to paying for better care, it's here to stay. It is permanent. The old way is gone. The real work now, the challenge that lies ahead, is what we see the vascular surgeons doing. It's the hard work of building these smart, tailored payment systems that actually reward what we all want, better health. And so we're left with this one big, final question. It's not about if we should pay for value anymore. That ship has sailed. The question is how. How do we design these models for everyone? Not just for the common stuff, but for every specialty, for every kind of complex patient, so that the money always, always follows one simple goal: actually making people healthier.